all. I'll be presenting a case series of the title Uveitis in Disguise. So case 1 is a 50-year-old lady presented with watering pain and redness in her right eye since 1 week. Her best corrected visual acuity in both eyes was 69N6 and intraocular pressure in the right eye was raised with 28 millimeter of mercury. And on anterior segment examination, the right eye showed conjunctival congestion, shallow AC and closed angles on gonioscopy. So when we examined the fundus, there was crowded disc and tortuous vessels with dull foveal reflex. She had earlier consulted in elsewhere and was diagnosed as right eye acute congestive glaucoma and was started on anti-glaucoma medications. She presented to us as there was no resolution in symptoms. When we examined the fundus carefully, we noticed that in the right eye there were choroidal elevations at the macula and in left eye there was hyperemic disc. We further advised OCT and we found multiple pockets of subretinal fluid with retinal pigment epithelium undulations, and ASOCT showed closed angles and a hyporeflective space in the ciliary body suggestive of ciliochoroidal effusion, and B scan was within normal limits. We further advised fundus fluorescein angiography and found multiple hyperfluorescent pinpoint dots temporal to the fovea with no leakage, and left eye there was disc leak. So we came to a diagnosis of both eye posterior uveitis, probably VKH, and we further advised investigation, the basic uveitic investigations, and all came to be within normal limits. So we advised oral prednisolone with gradual tapering. So 1 week post-treatment, the vision has improved to 6 parts with resolving subretinal fluid pockets and choroidal undulations. Coming to the case 2, it was a 45-year-old lady presented with blurring of vision in her left eye since 10 days, and she also gave a history of tinnitus. So her best corrected visual acuity left eye was 69N6, right eye was 66N6, and both eyes showed blurred disc margins with peripapillary fluid. She had earlier consulted elsewhere and was diagnosed as bilateral papilledema and was on treatment by neurologist with oral acetazolamide for IIH. When we carefully examined the fundus, along with the disc edema, we found choroidal elevations at the macula and subretinal fluid. And OCT showed thickened choroid with RPE undulations with the pockets of subretinal fluid. So we came to a diagnosis of both eye posterior uveitis, probable VKH, and investigations were within normal limits, and we advised oral prednisolone with gradual tapering, and 1 month post-treatment, vision was 6/6 in both eye, the disc edema had resolved, and the choroidal thickening had reduced, and subretinal fluid was also minimized. Case 3 is a 39-year-old male presented with blurring of vision in his left eye since 15 days, and vision in the left eye was 612N12, and on examination of the fundus there was subretinal fluid, and OCT showed neurosensory detachment. He was diagnosed elsewhere as left eye central serous chorioretinopathy and was given reassurance, but he presented to us as vision continued to worsen. And on careful fundus examination, we found there were multiple subretinal yellowish lesions in the macula with subretinal fluid. So along with the neurosensory detachment in the OCT, we found choroidal elevation, thickened choroid, and hyperreflective dots. We further advised fundus fluorescein angiography, which showed early multiple hyperfluorescent spots with late leakage and disc hyperfluorescence. So we came to a diagnosis of left eye posterior uveitis, and his MAN2, TB gold, and were positive with active lung lesions. So he was started with antitubercular therapy by pulmonologist, and we started him on oral prednisolone after 3 days. And 6 weeks later, we found his vision improved to 6/6 with decreased choroidal thickening, RP undulations, and his ellipsoid zone was restored. So in all these cases, there was misdiagnosis. The first case, there was ciliochoroidal detachment, which caused acute rise in IOP. and due to the inflammation of the VKH. In second case, VKH can rarely present as bilateral optic disc edema, so we have to consider it as a differential. In third case, there was overlap of symptoms and signs which led to misdiagnosis. So my conclusion is posterior uveitis is a sight-threatening disease and the clinical presentation can be myriad. So a high suspicion in atypical cases with detailed history, clinical examination, investigation become necessary in order to arrive at an earlier diagnosis and prevent the delay in treatment and therefore visual morbidity.